Anorexia nervosa is the most fatal eating disorders, but there are other eating disorders with major complications as well. So bulimia nervosa and binge eating disorder will be the subject of this lecture segment. So bulimia nervosa is characterized by binge eating, excessive amounts of eating in less than 2 hours, and loss of control over food intake. There are inappropriate compensatory behaviors, vomiting, using laxatives, diet pills, diuretics, exercise, and food restriction. Excessive preoccupation with weight and body shape. And he does these above behaviors at least once weekly. And as we said earlier, anorexia nervosa comes in a purging type. So this can't be better explained by anorexia nervosa, and I'll discuss that distinction a little bit later. Purging is induced by vomiting, with sticking fingers down the throat, and most bulimics, if they're doing this a few times, can make themselves vomit spontaneously. The use of diuretics or water pills, laxatives, stimulants, and caffeine. And there are quite a few stimulants over the counter, including dextromethorphan, which is present in cough medicine, and pseudoephedrine, which is a component of nasal decongestants. Both of those can result in decreased appetite and weight loss. So in bulimia, there's a loss of control over eating. There's disgust and shame that follows, and the fear of weight gain, and that leads the individual to purge. So the difference, since anorexia comes in a purging type, is that the anorexics lose weight. Remember, they have a low body mass index, 85% below normal, whereas the bulimics are either overweight or of normal weight. Just like the anorexics are divided into purging type and restricting types, bulimics are divided into purging and non-purging types. Well, what are compensatory behaviors that don't involve purging? Well, this would include things like fasting and excessive exercise. Another difference between the anorexic and the bulimic is the anorexic looks in the mirror and sees somebody who's fat. The bulimic has a more realistic interpretation of his or her body weight. So severity, all you need is purging once a week to qualify for bulimia nervosa, but that would be considered mild. As you get more severe, you see greater and greater numbers of purging episodes per week. How might a clinician suspect bulimic disorder or signs of purging in a patient? Number one, eroded enamel on the teeth due to the exposure to stomach acid from vomiting. Abrasions on the knuckles as the patients insert their knuckles into their mouths to induce vomiting. This is called as Russell's sign. Patient can also get swollen parotid glands, as the parotid glands are responsible for salivation, and you can get hypersalivation in patients with frequent vomiting. And clinicians' only tip-off might be on a blood draw that shows electrolyte disturbances such as hypokalemia. Russell's sign, that's the calluses on the knuckles, which are used to induce vomiting. And here is an example from Minnie Driver, who confessed that she suffered for years from an eating disorder, and you can see the prominent parotid glands. Looking at the erosion of teeth enamel, many of these patients have to go on and get porcelain caps. And so, although this picture looks pretty good, the teeth are more shiny and white than would be expected in normal people. And often bulimics, years and years later after they've recovered, will have these types of teeth, which are a tip-off that a patient has suffered from purging in the past. And here you get another look at these pearly white teeth. as signs of prior history of purging. So, bulimia nervosa, you've got recurrent episodes of binge eating, recurrent compensatory behaviors. Vomiting is not necessary to qualify for the diagnosis because all of these other compensatory behaviors can be used. Lifetime prevalence is higher than that of anorexia nervosa. Anorexia nervosa just below 1%, bulimia 1 to 3%. Sources differ on what they say the male to female ratio is. Some say 1 to 10, others say 1 to 3. Leave it that there's still, just like anorexia nervosa, far more females than males. Peak age of onset is a little later than for anorexia, with an onset of 16 to 20 years old. Interesting, anorexia nervosa has a lower prevalence in Latinos and African Americans. However, bulimia has a higher incidence compared to Caucasians. The bulimics will remit and then relapse, at least 30% of them. 10 to 15% crossover with anorexia nervosa. So anorexia nervosa can follow bulimia nervosa as a patient's purging behaviors result in diminished weight. Bulimia is easier to treat than anorexia because patients have insight. They have realistic impressions of their body weight. They know something is wrong. They don't like it. They don't like what they're doing. Anorexia nervosa has the highest mortality risk, but even bulimics have 2 to 8 times the mortality greater than the general population because vomiting can lead to electrolyte derangements that can lead to cardiac arrest. What are the other complications of bulimia? Mallory-Weiss tear, which is a tear in the esophagus, leads to hematemesis, or vomiting blood. Mentioned, you can have electrolyte derangements, sodium, potassium, magnesium. These can lead to arrhythmias, electrolyte abnormalities such as hyponatremia can lead to seizures. We talked about the dental complications. And Ipecac used to be available in pharmacies to help induce vomiting, for examples when a child would ingest a potentially poisonous substance. Parent would give the child Ipecac to induce vomiting. Well, it was discovered that Ipecac can induce a cardiomyopathy itself, and it's been withdrawn from the shelves in drugstores. I'm sure it can be procured over the internet, however. Complications of bulimia can include suicide. If a patient is tortured by their eating disorder and can see no way out of it, they may lead to them considering and perhaps hurting themselves. So the prognosis, 70% recover, 20% relapse and remit, and 10% are chronic. Prognosis is worse in frequent vomiters, substance misusers, patients with mood disorders, or personality disorders. Treatment, nutritional rehabilitation, so they'll need a nutritionist, they'll need a psychotherapist, their primary care physician will need to be involved, and the family will need to be involved, just like with anorexia nervosa. Cognitive behavioral therapy has the best evidence among psychotherapies for the treatment of eating disorders. There are even 12-step programs called Overeaters Anonymous that are all over the country, and patients can go and get support from other sufferers at these meetings. And whereas with anorexia nervosa, the only drug that's shown some promise is olanzapine, which is an atypical antipsychotic that promotes massive weight gain. But that's even arguably efficacious at best. But with bulimia, we've got a couple of options. Fluoxetine or Prozac at very high doses can reduce bulimic behaviors. There are other psychotropics effective for binge eating disorder, such as topiramate, which is an anticonvulsant. It's non-FDA approved for either bulimia or binge eating disorder, but can have a role in this condition as well. Okay, now so let's talk about binge eating disorder. So, unlike with bulimia, these patients do not have compensatory behaviors. They eat excessive amount of food in one sitting, like over 2 hours. They lose control, just like bulimics. And then they eat rapidly, they eat until uncomfortably full, they eat when they're not hungry, they eat when they're alone, and they're disgusted with themselves afterwards. So it's bulimia, but without the purging. They don't meet the criteria for bulimia because they don't purge, and they don't meet the criteria for anorexia nervosa because they're not underweight. And just like with the other eating disorders, you got mild, moderate, severe, or extreme. Now, binge eating disorder has the highest prevalence in the population amongst all eating disorders. In fact, before the most recent version of the Diagnostic and Statistical Manual of Psychiatry, also known as the DSM, binge eating disorder was not even recognized as a separate illness. But in the latest version, which came out, I believe, 2013, 2014, binge eating disorder was given its own label. So 6% lifetime prevalence. Here you see males less than females, but by a much lower margin. Median age of onset is older than with the other eating disorders, and the medical complications include obesity along with everything that leads to hypertension, hyperlipidemia, diabetes, and sleep apnea. Treatment, again, psychotherapy, Overeaters Anonymous, and we have some drugs that can work. Vyvanse, which is an amphetamine drug, is FDA approved for treating binge eating disorder, but high doses of SSRIs can be helpful, just like they can be helpful in bulimia. The anticonvulsant topiramate is used off-label for binge eating disorder, and interestingly, it is on-label for weight loss. And of course, with all of these disorders, you've got to treat the comorbid psychiatric conditions. Depression, post-traumatic stress disorder, anxiety disorders, compulsive disorders are all found with a high prevalence in eating disorders. So in summary, for eating disorders, we've got anorexia nervosa, bulimia nervosa, and binge eating disorder. And you all should know the criteria and the differences between those three conditions. It's potentially fatal, particularly anorexia nervosa, but bulimia as well, due to suicide, electrolyte abnormalities, and arrhythmias. There are over 10 million Americans with either anorexia nervosa or bulimia nervosa. There is 15 million people with binge eating disorder. And if we take subclinical eating disorders, that includes millions more. So you might say there's an epidemic of eating disorders in this country. There's high psychiatric comorbidity. Patients that need to be screened include adolescent girls, young adult women, young gay men, obese patients, and high-risk professions like we talked about earlier, dancers, wrestlers, athletes, models, actresses. Treatment requires a multidisciplinary team, family involvement, the treatment of comorbid psychiatric and medical illness, psychotherapy, particularly cognitive behavioral therapy, and we've discussed how pharmacotherapy can be an important adjunct. And that will conclude our discussion of eating disorders.